Hi, I'm Dr. Herb Raymond-Snyder. Symptomatic stone disease is very common and causes a great deal of pain. Most stones are better treated in an outpatient ambulatory surgery center environment. The goal is to have the patient back home the same day without the stone or the pain. This video is a guide to that goal. Kidney stones are very common in our society, and I want you to have a handle on what to do. This is one of those pictures you can take, and if you look at it, you'll say, why is he talking about this? If anything, this is cardiovascular stuff. But if your diet is right, it's not only good for your kidneys and keeping kidney stones away, but it's good for your heart and your blood pressure and keeping diabetes and those things away. How do you figure out when you have a kidney stone? Well, number one, it more often than not will tell you, and that's a big ouch. And it's usually a big ouch on either the right or the left side of your body. And that ouch has a traffic pattern that it's going to follow headed down toward your bladder. Most people who have acute onset of kidney stone pain wind up in the emergency room. And there's some problems with that. And I'm not blaming the emergency room at all. As a matter of fact, we do a lot of stone disease here at the Knightsbridge Center in caring for people who have it. And many of our patients come out of the emergency room. They get tired of sitting in the waiting room waiting with the pain. And somebody around them has had ambulatory treatment for kidney stones. And you can understand it. If somebody comes in and it's an automobile wreck, or somebody's had a gunshot wound, which is going to come first? You with the backache, or the person who had that problem? Let's read this. If you've ever had a kidney stone, you know what pain is. You've waited in an ER only to see the real emergencies. Go ahead. Then after what seems like an eternity, you are sent home with pain meds, or admitted, or treated in the next day or two, depending on the schedule and how crowded it is. What you want is treatment promptly, and to go home to your own bed. At Riverside Urology, that's our goal, that you go home to your own comfort zone, and preferably without your stone. And we have the capacity to do that a significant portion of the time. Our kidneys are really, next to our heart, probably our most important organ. The liver's in there pretty close. But the kidneys allow us to have adequate nutrition, to do the things that appeal to us, even if it's excess. They clear our system of substances that if they don't clear, we get very, very sick. A stone coming out of the kidney can block the kidney here, and that truly would be a kidney stone. But most of the things that we're probably talking about are ureteral stones. So why does it hurt so much? Well, here is a picture of the kidney. This is called a retrograde pyelogram. And down here, this filling defect is actually a stone in the ureter. And this is backed up, and this kidney tissue is stretched. And when that's stretched, that's what causes the pain. This is called a CT scan or a CAT scan. And what this is a radiograph that's really a good picture, and is particularly good for taking pictures of stones. And so we know in this case where the problem is located, and that's the beginning of the solution. There's another point, and that is that when you have pain and you think, well, maybe I got it, maybe I don't, what should I do? The sooner you do something means the sooner we can get involved, and the easier it is to take care of the problem. Why would that be? Well, if the stone comes down through the collecting system, and that collecting system is getting smaller, pretty soon it gets stuck. And when it gets stuck, guess what happens? The tissues around it swell, and it's almost like it's glued in place. On the other hand, if you begin to have pain and you're concerned about it, and you call your doctor, if you have a urologist, we take calls. We bring patients in every day who call us because they have a problem. Early treatment is key to easing the problem of stone disease. So this is the building we're sitting in. We built this building, and right on the other side of this wall is a surgery center. This is what our place looks like, and they're taken care of. They have a nurse. More often than not, the patient knows the nurse name, and the nurse for sure better know the patient's name. So let's talk about some of the basic physiology. Kidney, ureter, bladder. This anatomy, because it starts big and winds up very small down here as the ureter enters the urinary bladder, many places for stones to get stuck. And when they get stuck, it's not the stone getting stuck. It's plugging up the ureter so the tissues stretch. That's where the pain comes from. So I don't think there's anybody in this room that would imagine that that stone is going to glide down this ureter into the bladder without raising a fuss. So that means we need to be there. We need to help you. But before we can help you, you need to be a little bit educated about this so you know who to call or what to do or where to go. If this has been going on for a while and the stone is impacted or there's swelling around the stone so it can't move, and then the area of the ureter and kidney above it is plugged up, is we want to relieve that obstruction. When we relieve the obstruction, the swelling here will go down. So much so that there are patients that I've put a stent in, and I've looked at them then a day or two later with a radiograph, an x-ray picture, and the stone's down here. And I say, wait a minute, maybe if I just take this stent out, which you can do in the office, you'll pass the stone. And I would say that about 75% of patients who have that scenario actually do. But that's not good enough for the other 25%. So you got to be careful how you make those decisions. And we'll go to this topic, ureteroscopy, in a moment. Anesthesia in an ambulatory surgery environment is very different than anesthesia in the hospital. The anesthesiologist who works in the surgery center is accustomed to putting patients asleep in a way that they can bring them out of that slumber very quickly. And many times the patients say, is it done? Did you really do something? So we really have ambulatory anesthesiologists. Ureteroscopy. This is really a development that's occurred in probably the past 20 years, and it's got better and better and better. This is called a C-arm. A C-arm is a device that gives us a picture of an area that we're interested in, so we can find out where the stone is. If we put a stent in, we can see the stent's going in the right place. If we put a ureteroscope in and we're in the kidney and we're going into the upper pole and the stone's in the lower pole, we can see that we're doing that, and all we do is back off and we go to the right location. I would say that this is really the heart of the evolution of treatment of kidney stones that has occurred in the last 20 years. This is the ureteroscope. I'm going to stick with the flexible ureteroscope. This is a very small instrument. This will slide up the ureter. A normal ureter, you can just put it right up the ureter like a stent, and you can see everything that's there. And here's the ureteroscope. We passed it into the bladder. We can find entry, then we can find the entry of the ureter, then we can go up the ureter to the kidney, and we can locate the problem. But here's our stone. Here's our ureteroscope, and we put it up into the kidney. And then we can put one of these wires through the scope, and you can open this basket and close this basket. And here's another picture of the same thing. We see these stones. We can relocate the stone in the kidney to a place where we can treat it without creating a lot of havoc. This is a laser fiber. This is called a holmium laser fiber. Puts energy into the stone and cracks it so it will start to fall apart. With the laser fiber, to turn this into gravel, powder, whatever you want to call it. There's a technology where we don't have to invade the body at all, and that's called extracorporeal, meaning out of body. Extracorporeal shockwave. Lithotripsy means that if you can focus the stone in a focal point, then you can deliver energy to the stone and not do anything to the tissues in between. A shockwave travels through water. We're made of water, and the rest of it is just a masquerade. So we can apply shockwave, focus it on our kidney, and break the stone without ever physically touching it with anything I've shown you up to now, except the radiograph that tells us where the stone is and shows us how to focus the system so we're actually treating the stone. This is the area that receives the energy that this area is focusing on, and this is a radiograph that keeps us on target. So we can adjust energy and we can focus energy on the stone. CT remains the foundation of imaging study. Defines stone burden, tells you where it is, gives you a pretty good idea how to get to where you need to be. Here's our CT scan again, and here's a stone that has caught our attention. So there's what the stone looked like on a plain X-ray. And this now is the stone on the image of the lithotripsy. So we now have this stone in focus, and now we're going to, quote unquote, blast it. And this gentleman obviously is quite comfortable. And here's a patient. He's getting his stone treated with lithotripsy. The shock wave is down here. We image it. We put it on the kidney. The focal point is here. The stone is broken into small fragments. And it does pretty much what the laser does, but it does it without physical contact. And you can pass these fragments and not really have much discomfort. So these are the shock waves that fragment these stone particles, and they pass out without much ado. We have to have the patients hydrated well. We give them some diuretics so they have a good urine output, and they just literally flush the system. This is the area now where the stone was but isn't. And this is the area where the stone was but isn't. This MET stands for metabolic expulsive therapy. In other words, if we have a stone early, it's relatively small, and just for your information, the diameter of a stone that we have high hopes will pass is about 4 millimeters. 5 millimeter stone can pass. 6 millimeter stone, we have to go to work. But let's say we have a 4.5 millimeter stone. We could give this individual an alpha blocker, and there is a medication called tamsulosin. Some of you may be on it. You used to call it Flomax. So if you give a patient who has a stone diagnosed early, small stone, let's say 4.5 millimeters, 2/3 of the way down the ureter, you could give this individual tamsulosin, and that will dilate his ureter to a degree. And you could give him Lasix, which is a diuretic, and you could push the stone out just by water dynamics or urine dynamics. So that's what expulsive therapy is all about. The diet that you take to give you healthy heart also, for the most part, gives you health in your urinary tract and keeps you from forming stone. When you think you have a urinary tract stone, call a urologist if you know it. No one. Tell them your stone pain has just started, it's reminiscent of what you had before, and you'd like to get in and you'd like to have something done soon. You would like to have that doctor associated with an ambulatory surgery center so you can use the lighter weight, rapidly mobilized system as opposed to sitting in the emergency room waiting for the gunshot wounds and the traffic accidents to clear so they'll do something about your backache. I did do a video on stone prevention, and it is on our website. and you look up on YouTube stones503, you'll learn about stone prevention therapy. I've told you how to treat stones and how we do it. Now I'm telling you how you can improve the situation and keep those stones from developing.